if you are ever wondering, hey, can I be an antibiotic steward? It does not matter what you do, what your role is. There is a role for you in antibiotic stewardship. When it comes to the inappropriate use of antibiotics, often the risks well outweigh the benefits. And if we can decrease the inappropriate use, then hopefully we can make a dent in some of those adverse outcomes. I explain it to them and I explain how we're going to use the antibiotic and I explain why. And once they do that, it's like the light bulb goes off and they are so on board because they realize not only are they helping keep themselves safe, but they're also participating in helping keeping the community safe and healthy as well because of your comment earlier. So it's so cool when patients really come on board with antibiotic stewardship and they realize how powerful antibiotic stewardship is in the grand scheme of keeping everybody healthy.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists, episode number 245. My name is Andrew.
And my name is Michelle. Welcome to our podcast. If you're new, we do this little intro where Andrew and I catch up. If you're old, I think a lot of people enjoy it. And if not, you could just skip to the interview, which is pretty great today.
And we have that located in our show notes. So if you guys are just want to jump through, usually we have like a little timestamp of when the interview starts. So don't feel like you have to listen and catch up with us, but we really want you to be here listening to all the good stuff that our guests have to bring you. So a couple of little things.
Okay.
So some people know that I've moved to Florida and we're like trying to close on a house, but we're trying to close on our house in Washington and we're doing all these things. So I apologize right at the very get-go. There's some weird noises above me in this Airbnb that we're staying in from like people just tromping around. This little community that we're in is heavily, we're right next to University of Tampa. So tons of students, little 20 to 24-year-olds just running around having a good time.
Hopefully masked.
No, they're not.
Ugh.
So I took the kids to the pool and there is some obviously adult beverages going on and some other things going on over there. I'm like, okay, kids, it's time to go. We're
recording Labor Day weekend. So
this is
that's the normal level of debauchery.
This is the normal. I mean, yeah, it is. And so the apology, I have this in the hallway behind me. I don't know if you guys can hear it. I hope you can't because we have pretty good mics, but
I can't hear it.
There is this fire, the smoke detector when the battery's out, it's like beeps at you.
Oh, yeah. Oh, that's so annoying.
Like reverberating off the walls. I woke up at midnight last night and couldn't really go back to sleep because I kept hearing it over and over and over again.
Yeah, that's the most annoying.
Yeah. And then maintenance, of course, is off for the weekend, right? So like, okay, whatever.
So that little beep is just going on and on, and I would rip it out of the wall. I will take drywall. I will take all electrical.
It's like 10 feet up. Like I have nothing I can use to go get it, or I would change the battery myself to make that thing stop. But I don't, also I'm like, well, I don't know if I'm allowed to. There's cameras everywhere. Anyway, so I apologize, listeners, if the audio quality is not that good. And also, while it's really cool, but the poured concrete flooring that they have in some homes, that's what this is. So I have all those hard walls you see behind me, the big lofted echoey ceiling.
You just have like a podcaster's nightmare happening
just a
over
nightmare
there.
Here. Just a nightmare. But you know what? I'm happy to be here. It's still fun to podcast. So
that's good. That fire alarm beep would make me become straight up Hulk. Like,
yeah.
Talk about a trigger.
Can we talk a little bit about what happened to your face? And can we take some pictures of it and then show all of our listeners everyone?
It's so much better.
It's to be a visual podcast sometimes, even though I disagree, but only when it's like focused on me. When it's focused on her ugly face, I am happy to see it.
And not just my face, but my bruised face.
Oh
and
my
how
gosh.
ridiculous.
Now, the one that's on your forehead looks a lot better.
That's a lot better.
This one
I can't even believe popped up.
People have no idea what I'm talking about.
So I don't remember, what day was that? Like Tuesday? I can't remember now what day. Anyway, because of the corona, I'm not really in the mood to go to a gym, right? Like I'm just don't trust it. I'm sorry. Like people, I don't even care if you're like every other treadmill at this point. You huffing and puffing around me doing exercises and just not in the cards for me. I'm just no. And it's too hot. I'm in Charleston. It's like 109. It feels like 109 outside. So I'm not exercising outside and I've been a real slacker. So I turned what was like my studio with like my green screen and all the things that I had to film videos, kind of moved that to the side and made this one little, what they like to call in this, my townhouse, a third bedroom, but will eventually be gutted, and try to make that my little gym. And I have, you know what, apparently a lot of people don't realize that I once upon a time was a dancer. Like I did ballet and did all the stuff. And so I like being a little adventurous when it comes to types of exercises. So I have a yoga swing and a TRX band, right? And like the yoga swing where you can hang upside down and do all the aerial things to stretch and do yoga poses and stuff. It's not a sex swing because a lot of people have been like, oh, what is that? I'm like, I swear to God, it's just a yoga swing. Right. But you have to screw it into the bolts of your ceiling or like the headers of your ceiling and have some pretty decent, sturdy bolts. Well, I went to go put it up in my thing and I guess the fixture, the bolt that actually gets like screwed up there, it's really heavy and very sturdy. And the drill like swung out of my hand and the thing dropped and slapped me right. It hit me in the forehead and I felt it hit me here in the chin, but this didn't bruise until like 2 days ago. So this started to heal up and then all of a sudden this started turning green down here on my chin. I was like, oh, so it hit me twice in the face. So there's that.
It looks awesome. Hopefully you're feeling better.
It looks like I got punched in the chin.
Yeah. Which, as mouthy as you are, I don't put it past people.
I know. I wouldn't put it past a lot of people to wanting to slap me in the face. But luckily we are masked up. So pretty much everywhere I go, I got a mask on or I just stay home. So it works.
Good point. Hey, are we allowed to talk, by the way, about that mask that I've been seeing on social media a lot lately? Oh, we have to.
Yeah, I think so. Yeah, sorry.
It's called Clara.
And if you can go to breatheclara.com, you can see what we're talking about. I had signed an NDA months and months ago. So I've been doing some infection control stuff for Cherie, who you guys might have heard on the podcast. If you're familiar with Armored Dental and MouthMate and ScanMate, she was the creator of all both of those products and just came out with a new mask called Clara. And it is going to hopefully replace our N95s and the need for a reusable mask. And it does look very Avengers, like, I don't know, like it's an interesting mask because it has ports on the side of it with these like tubes that'll go down to a HEPA filter. So you're breathing and expelling air that's going through and in and out of a HEPA filter. So you're essentially breathing clean air and you can disinfect it in between patients. You can replace it. Have like my thing was, let's have 3 of these little CPAP looking mask things. So you just like unhook the ports and replace it while the other one, because like the rule of 3 in dentistry where you have like 1 in use, 1's dirty, 1's ready, like that kind of thought process. So we'll see what comes of this. It's not exact. I mean, they've at least put it out into the world. I don't know if you can order it or if it'll be shipped just yet to you, but super cool if you are really into not fighting these N95s anymore and into the environmental side of what all of the PPE that we are wearing these days is doing to our world.
No, so disclaimer, I haven't actually used it yet, but it looks like, okay, so you know how and then you have everything's like right in your face. With these masks it looks like Cherie had a little bit of breathing room.
Yeah.
And it goes up over the bridge of the nose a little bit, but it didn't look like it was just like smashing into her face. So it looked like she was able to breathe. She was able to talk. In my last area that I had, we had a school for the deaf. And so we had like a lot of people that could read lips. And now we always had a translator per their request anytime they wanted it, that could do sign language. But a lot of our patients didn't really need to. And so, having these double masks or these N95s, whatever, that basically made it so that we had to have, translators every single time, every single visit. And so something like this where it's clear, see-through.
Yeah. And it has a spot in the front it's a speaker port. So it has holes in it, but the inside is like a silicone. So it's not hard. So it doesn't make you super like clear to hear, like, if I was talking to you and wearing this mask, but it does allow a little bit more sound to come through the silicone versus the hard plastic. So
it just looks a lot more comfortable.
All around the seal is silicone. So it
looks soft.
Going to, like really form and seal to your face. It comes up under the chin just a little bit to, help with that seal. But then the ports and everything go behind you, or you can put it on your arm. I know Deborah Carrier's from Twice as Nice that we love so much. She's creating like a harness to wear the packs on the back.
Oh,
but
nice.
You can essentially go and it can clip to your scrub bottoms if you wanted it to. I'm excited for the harness because then I'm hoping like my loop, because my light is one that goes behind me and kind of goes down my back, and then I hook it somewhere on my body. And that's been the hardest thing for me with the PPE right now, and us having to change it is like the light cord that goes with my loops. So
yeah,
I'm hoping this will like consolidate everything and put it behind me and my back and it under my lab jacket, which I think would be so cool.
It would be. Yeah. We have a review. You want me to read that real quick before we jump into the interview?
Yeah, let's do it.
So this review is 5 stars.
Whoop, whoop.
And it is from Kat RDH. She said, "What a great duo. Michelle and Andrew bring the daily struggles of hygiene life into the open. The banter, the solutions, and the quality of content are top notch. The guests are pretty cool too."
Agreed.
Winky face.
Oh, nice.
Yeah. So thank you, Kat. That's awesome. Absolutely true. Our guests are pretty cool, honestly.
They are pretty cool. I love that they think we're a great duo. That's sweet. Because strangely, we are so complete opposites. Oh, it's so funny.
I know
how different.
But
it's funny. We just talked about this because I was like, had these fluoride questions, and I was like, I've placed fluoride varnish about 30 times in my 20-year career. And you're like, what?
I wasn't trying to be snarky, but I'm like, she texted me a question. I'm like, let me call you because I'm like, is this a serious question? Because that is a duh. That is such like 101 hygiene, I thought, but maybe not. So,
but when you don't play, same with sealants. Like, even when my students, maybe they were trying to get their comps done, and they're like, "I'm going to place 8 sealants today, Miss Strange." I'm like, "Okay, let me go get Miss Bodiford because you don't want me as your faculty. I can assure you that you don't want me helping you figure out how to place sealants because I don't do it. Now, if you want some advanced techniques on the distal of number 15 with the 6 millimeter pocket and furcation involvement, I'm your gal. But don't come to me for the varnish. How do I take an x-ray on a 7-year-old pedo? No, I'm going to go find somebody else.
Yeah.
That. But we've definitely had very different careers and we're just so different, but we have a great guest and we have great, like we complement each other because the things I don't think about, you think about. So it's great.
Sure, for sure.
Anywho, speaking of great guest, I have one amazing dentist that I was so lucky to hear at OSAP this year. Oh my gosh. I think it was this year.
Corona screwed up her time frame for everything.
I don't remember, but I feel like it was this year at the boot camp. And she was talking about antibiotic stewardship, which, is a big thing. This is not Dr. Kennedy's. This is Michelle's opinions, but my God, dentistry needs to do a better job because I am sick and tired of hearing people like, well, just give them an antibiotic. I'd rather just be safe. And I'm like, you actually aren't being safe. Like you're creating a bigger problem. I say it in this interview, but one of the quotes that has stuck with me for a very long time, and I brought this up with Amber Riley years ago when we did this, an interview at Chicago Midwinter, but I was like, antibiotics, it's one of the only drugs that you can take that will affect me. So if you're overusing them, you could create your antibiotic resistant bacteria in your little body, and then I can get it and there won't be a way to help me because it's resistant to the antibiotic. So it's not just like, let me take an opioid and an antibiotic and call it a day anymore. Like we have to be way more responsible about what we prescribe and what we give out. we need to start some serious interdisciplinary collaboration with, not physical therapists, orthopedic surgeons, and cardiologists. Like, we can't just be willy-nilly, like, let's just across the board give everybody antibiotics. Like, we got to change. So that's kind of what we talk about today. Dr. Kennedy goes through all kinds of like practical things, like ways that we can really think about like what we're doing, how we would prescribe it. And there's all these workflows available. And she talks about all of those in the podcast, but they'll also be in the show notes. So be sure to check that out and enjoy this episode with Dr. Erinne Kennedy.
Hey, Michelle.
Yeah.
It's time for the interview.
Oh, but I had something else to say.
We need to let the experts talk now.
Fine.
Well, listeners, I am so excited to have this topic on the podcast. I want to welcome Dr. Erinne Kennedy to the podcast. She lectured at an OSAP meeting that I was very lucky to attend. It was an amazing presentation. I think I even did some quick shots of the screen and like put it in social media. I was like, y'all gotta listen and y'all gotta like follow antibiotic stewardship. This is a big deal. So thank you so much for coming on the podcast and educating us a little bit more on this topic.
Thank you so much, Michelle. I'm super excited to be here today. And like you, you know that I'm really passionate about antibiotic stewardship. So I can't wait to dive in. Over the past few years, I've been practicing in New England. And within the past year, I was working with the Massachusetts Public Employees Fund as one of their preventive dentists. And recently, actually in the midst of the last few months, I have taken a position to help start a new dental school in Joplin, Missouri. So I will be helping Kansas City University develop some of their education programs, and I'll be teaching dental public health there. So I'm really excited. I'm moving from solely clinical practice to more of a hybrid role, and I'll still be doing so much of the research that I do here with antibiotic stewardship. I actually got started in a pretty roundabout way when it came to antibiotic stewardship. I don't think I've ever shared this story with anyone, but I guess I can start with you.
Excellent.
I don't think anyone knows this. I was sitting in a Seattle Study Club, annual symposium meeting years ago, probably 5 years ago now. And I remember the speaker happened to be talking about an element of antibiotic stewardship, but it wasn't exactly related to antibiotic stewardship. And I remember taking a bunch of notes and thinking, we really need to be better stewards about antibiotic use in dentistry. I said, I want to be somebody who makes a dent in this. And I have the journal that I wrote this in years and years later. And over the course of the next few years, I happened to be in my dental public health residency. And so I worked with a mentor to start a project looking at antibiotic use and Clostridium difficile outcomes in hospital settings and how those were related to dental outpatient antibiotic use. And one thing led to another. I ended up partnering with my mentor again to create an antibiotic stewardship toolkit for the state of Massachusetts, which we'll talk about today. And I also was brought in by the American Dental Association to be one of 12 panelists that helped write a guideline on antibiotic use in dentistry. Specifically, we looked at the antibiotic use around emergency situations or acute dental pain and swelling. And so we had a really diverse expert panel that was a part of those guidelines. And like I said, I was one of 12, but everyone came from a different position and just mindset. And it was really fantastic. We had emergency medicine physicians, microbiologists, internal medicine physicians, people who were experts in infectious disease, a pharmacist, myself. And so it was really, really fun. And I got to join the ADA methods panel and everyone at the ADA Center for Evidence-Based Dentistry to help bring these guidelines. And we're going to talk about that today too. But that's how I got involved in antibiotic stewardship. And so much of it started as a dream about 5 years ago.
That's incredible. I'm curious though, like so let's say we have a listener or even a new graduate, and we have lots of students that listen to this podcast, and they've never even heard of, let's say, antibiotic stewardship. What does that actually mean?
Absolutely. Defining antibiotic stewardship, it's really important to understand that it is a subset of antimicrobial stewardship. So antimicrobial stewardship is when you've designed this coordinated program that promotes the appropriate use of antimicrobials. And if you think, let's pause for a second and think about all the antimicrobials we use in an operatory. We use antimicrobials in our hand soap. We use Cavi wipes. We use, sprays, right? We also use antimicrobial, and this is kind of crazy, but think about it this way. We also use antimicrobial mouth rinses, and we use antimicrobial, chemicals and different materials inside teeth. Let's say when we're doing a root canal. So we use a lot of antimicrobial substances in dentistry, including antibiotics. So antibiotic stewardship, like I said, is a subset of this bigger picture, which is antimicrobial stewardship. And the actual, a scientific definition, then I'll break it down a little bit, is coordinated interventions designed to improve and measure the appropriate use of antibiotic agents by promoting the selection of the optimal drug regimen, including dose, duration, and route of administration. And so I'm going to break that down because I think a lot of times when we think of that, it's hard to think about what it would be like in dentistry. And so sometimes it's easier to think about it in a hospital setting. Oftentimes, hospitals have an entire wing or department, usually in the segment of infectious disease, that monitors the use of antibiotics in a hospital. And what they want to make sure is that you are choosing, all healthcare providers are choosing the correct drug for whatever the diagnosis is. So we don't want to have a drug when the diagnosis doesn't warrant an antibiotic. A good example is an upper respiratory infection. Most upper respiratory infections are viral, right? And for so many years, our whole healthcare system was kind of giving out antibiotics regularly for something that's for a virus when we're giving an antibiotic to take care of bacteria. And so there was a huge push in medicine. They've done so much work to change the mindset of, we don't automatically give an antibiotic for an upper respiratory infection. We really try to make sure we provide palliative and supportive care, increasing your fluids, resting, and then only giving the antibiotic when it's absolutely indicated when you actually have a bacterial infection. And so we want to make sure that you only get it when the diagnosis is correct. But more importantly, we really need to make sure that the dosing is correct, the duration is correct, and the route of administration. And you think, well, how could you mess that up in dentistry, right? Or how could someone inappropriately prescribe an antibiotic? Well, you know what? Life happens and we're all human. And a couple of the ways that inappropriate use can come out in the definition of antibiotic stewardship, a good example is dosing. So making sure that you give the right dose for an adult, and duration comes into play to make sure that you give it for the right amount of time and you follow up so that it's discontinued at the appropriate time. And we'll talk about that a little bit later today. And also the route of administration. In the case of dentistry, for the most part, when we're talking about prescribing antibiotics in an outpatient setting, we're giving someone either a tablet or a pill. It's the oral form of an antibiotic. But this comes into play when we're also in a hospital setting because you may give that antibiotic in a different way. And it's really important to make sure you consider that when you're writing an antibiotic prescription. And so when we look at antibiotic stewardship, it's not simply a provider practicing and stewarding how they dispense antibiotics. It's also this whole program around the solid and the stewardship practice of antibiotic use that incorporates education and stewarding champions in antibiotic stewardship, even evaluating and tracking how you are prescribing antibiotics. So it's more than just a practice. It's this whole coordinated effort. And I like to relate it to what we see in hospitals because I think it's a lot easier to understand.
My question is who can actually practice it? Because I'm a hygienist. I can't prescribe antibiotics to anyone, but what I can do probably is not accept them if I am being prescribed them for a sinus infection like I often get, or discussing that a little bit more in depth with my healthcare provider, because these days I just feel like I had a friend the other day that was like, yeah, I did a telemedicine thing. I have some swollen lymph nodes and they just gave me some antibiotics. And I'm like, But why? And like, what's happening? Do you know anything else? So as a hygienist, how can we practice antibiotic stewardship?
I'm so happy that you asked this question because I firmly believe that everyone can practice antibiotic stewardship. A little bit later, we'll probably talk about all the steps to creating an antibiotic stewardship program in a state and how it can apply to your practice. So stay tuned, I guess. But what I want to say is it's more than simply being the person that can write the antibiotic. A good example is antibiotic prophylaxis. When we have antibiotic prophylaxis, oftentimes the dental team member, that is the person that collects, the medical history, gets all of the background information, does so much motivational interviewing with the patient on different aspects, let's say before they're cleaning or whatnot, whether or not they need antibiotics. Oftentimes that's the hygienist, right? That's the dental team member who champions that entire effort. And so understanding the guidelines yourself and being able to collect the necessary information, and I'll talk a little bit about that today. One piece is understanding allergies and asking enough questions to truly understand a true antibiotic allergy. That is totally your role. You're actually the stewardship champion in this case because you're collecting all the data, you're educating that patient, you're setting them up for success, you're understanding when they should and should not be prescribed an antibiotic. And then you can bring in the other team members that are going to be involved in that interdisciplinary care, which oftentimes is, the dentist, one, but two, also maybe a primary care doctor, a surgeon. And I know at my practice, we had medical consultations, just like so many other practices. And oftentimes the lead hygienist for that patient, the person that was championing their care, would be the one that would help reach out if we had any trouble getting in contact with the PCP or a surgeon, right? So sometimes if things got a little tricky, they knew the patient so well and they knew the medical history, they would often give that provider a call, and they act as this liaison between our practice and another practice. And they were practicing this amazing interdisciplinary healthcare. And actually, if you think about it, in that space and in that role, the hygienist is the absolute antibiotic steward. They are helping all teams understand what resources are available, what this patient needs, how they can best be helped, and ultimately acting as an advocate to make sure antibiotics are used in dentistry when they should be used, right? And less when they should not be used. And so when I look at it, and actually when I was helping design our state toolkit, one of the elements to making a commitment was actually identifying a stewardship champion in a dental practice. And one of the recommendations I was writing out for this toolkit and partnering with the CDC and so many of their ideas was having a steward that not only helps lead education for team members, but promotes the use of posters and education and materials and follows up and makes sure that everyone receives training each and every year so that the whole team is practicing antibiotic stewardship the best. So if you are ever wondering, hey, can I be an antibiotic steward? It does not matter what you do, what your role is. There is a role for you in antibiotic stewardship.
So if I have a listener right now that's just feeling fired up to be that champion, right? Or maybe they have kind of always known this and get a little pushback from other clinicians who don't really are not ready for that shift or not wanting to see the need for the shift. Where are those resources? What can they go get, and how do they find that?
First, I would check with your state. When I started in antibiotic stewardship a few years ago, there were only a few states that were really championing antibiotic stewardship at a state level, meaning they developed a toolkit, they were collecting data, they were providing trainings and resources for dentists across that entire state, right? Some of those states were Illinois and still are Illinois, Massachusetts, Minnesota, Michigan. And they're still championing these efforts. But I would definitely check with your state health department and even your state dental society to see if there are specific state resources. Because if there are items specific for your state that all of these coalitions have got together to create for you, I would start there. If not, borrow from someone else. The Illinois state toolkit, the Massachusetts state toolkit, and I can give you all of these links, Michelle, so you can include them in the show notes. But using those two toolkits will be so helpful. Specifically, and I'll speak to the one in Massachusetts because I led the team that developed that. you just read it cover to cover and it walks you through step by step. Step 1, do this. Step 2, do that. Step 3, here is, this information that you need. And what's really amazing, and we can actually talk about that right now, I can walk you through what that toolkit looks like. And I think it's actually going to be super helpful. So the toolkit is based on the CDC framework for antibiotic stewardship in outpatient clinics. And the 4 steps, or actually the 5 steps to these appropriate stewardship practices from the CDC are this, and I'm going to read them off to you so that you know what the framework is, and it sets up understanding the toolkit a little bit better.
Perfect.
1, it's to demonstrate a commitment to optimizing antibiotic prescribing and patient safety. 2, use evidence-based diagnostic criteria and treatment recommendations. 3, implement at least one system to track and report antibiotic prescribing. 4, complete a survey for self-evaluation of personal prescribing practices. And 5, educate patients on appropriate antibiotic use and potential harmful effects. And so I'll walk you through how you can apply these to your practice, no matter where you are. Step 1 would be making a commitment. And you probably think that it's going to be easy to make a commitment to antibiotic stewardship, and I think it is. But actually, research shows that it's pretty tricky and you get a lot of pushback. And I, for one, as a practicing dentist, can tell you how many times I've worked with another provider that's disagreed with me and patients who have received an antibiotic for maybe 20 years and no longer need it, or it's no longer indicated by these evidence-based guidelines. But we have to work to have that solid conversation to be able to create those changes. So first step is making a commitment. Examples that I share when I'm working with practices and community health centers to implement this are posters. You can put up a ton of posters, but remember, be creative. How many times do you have a TV in an operatory, like a TV screen that you use for treatment planning or other patient education? You can use that in the operatory. You can put that in the patient waiting room. You can post information on your social media and on your websites. And if your practice has a newsletter, you don't have to just confine antibiotic stewardship to the operatory. You should be talking about that on all of your platforms. For example, we have posters and information that you can customize in our Massachusetts State Toolkit that you can use on your social media, that you can use on your website, that you can put in your newsletter. And all of that is easily downloadable and converted to whatever form you need. The second is identifying that champion. And this champion has a really important role because they're basically the leader of antibiotic stewardship in the practice. And in the beginning, I was working with a few different colleagues and they thought, well, this has to be the dentist. And I really pushed back because I actually don't think so. And the reason I thought this is because I thought of infection control. And I worked in a community health center where we had a lead dental assistant who basically ran all of the elements of infection control and was the leader of that in the practice. And let's say there was someone else who did all the ordering. It might not be the same person, but each person was given this task and they are the steward and the champion of that task. My point was that why don't we make someone the lead antibiotic stewardship champion? And typically, especially in the practices I've worked in, it's oftentimes somebody who has a personal story. For example, I've had people in my family that have suffered from Clostridium difficile while they were living in long-term care facilities. And so my passion for antibiotic stewardship stems from a very personal level of saying, I have an opportunity in dentistry to make sure that I am influencing other providers and ultimately protecting patients, just like my own family member. And so oftentimes when I'm talking to somebody about antibiotic stewardship or I'm working in a practice, I kind of bring it up. And there's always that person who's like, I'm so thankful we're doing this. And this is why, and this is how it affected me. And often they create the best stewardship champions. And the other piece, and this is really important for making a commitment, it's not why you sign your license or anything like that. But when we write down a commitment and then we sign our name to it, there is a switch that goes off psychologically that helps us keep that commitment. And so when you download those posters from the Massachusetts toolkit on antibiotic stewardship, it shows you where you can put your name and even a photo. And then it recommends that you take a black permanent marker and you sign that and say, I am going to make a commitment to antibiotic stewardship. And oftentimes it's, especially in their research, it's the provider that signs their name and makes the commitment. But the more and more I study antibiotic stewardship, the more I think the whole team needs to sign that poster, and you need to make copies and make that commitment all across your practice. So that's the first step.
And what a great thing to market, like to add in your marketing plan and show, put it on your social media that you guys are doing this training and signing this commitment, put it on the wall next to your license. Like, why not?
Absolutely. And, it's just something that it really brings the whole team together around a very similar topic. And it's so important. And I think in today's day and age with the rise of antibiotic resistant infections, most people are aware of this and they're wanting to find ways to protect their friends and family. So section 2 is act. And I think that's the first thing we think of is, okay, what are we going to do about it? Right. But you have to make a commitment before you do anything. So the second piece is act, and ways to do that are using evidence-based diagnostic criteria and treatment guidelines, providing communication and training within your practice, practicing delayed prescribing or watchful waiting. And I can give you an example of that. And then also providing support for clinical decision-making. So when it comes to evidence-based guidelines, we can talk a little bit about some of the ones that have come out in the last year today, but it's really important to make sure you use tools, especially chairside in your decision-making. If you go to ada.org/antibiotics, there is a step-by-step tool on there that allows you to walk through decision-making when someone has acute pain and or swelling. And it's a really great resource to have on your save tab in your clinical computers and your operatories. And I find that to be really helpful for almost anyone trying to practice antibiotic stewardship. I think it's really important also to provide communication training. And the example of this I give is always role playing. I don't know about you, Michelle, but I always find someone who's received an antibiotic, especially for prophylaxis, for probably, let's say 15 or 20 years.
Yeah.
And we sit down and we go over their medical history and we look at the evidence. And based on the evidence today, that antibiotic may be no longer indicated or is no longer indicated. It is a very hard conversation to have with that patient because there's some security for them around taking this antibiotic. And it's not even just security. It's like a habit of doing it before every dental appointment. And it's really hard to break that habit. And so in my practice, I like to spend a lot of time role playing, especially with different team members who are going to be having some of these conversations right when they walk into the door or right before they're cleaning or something along those lines. So I like to do a lot of role playing because I find that it's one thing to watch a training online. It's another to practice and be like, oh, this conversation's harder than I thought. And it was it's typically really helpful to practice as a team because each and every person brings a different element to that conversation and you can really refine that and make it a little bit easier. And then I mentioned something called delayed prescribing and delayed prescribing. Another example, remember when I talked about the upper respiratory infection just a few minutes ago?
Mm-hmm.
So in medicine, they started doing this around upper respiratory infections a while ago. So let's say you go in for an upper respiratory infection and it's viral. It can turn into a bacterial infection. And part of it is that let's say you get to a point where, in the beginning, they just say, all right, I am going to have you, have some palliative care, get a lot of fluids, get some rest, make sure that you take maybe some of these supportive medications to help with your symptoms. And let's say your upper respiratory infection starts to progress a little bit. It may get to a point where an antibiotic is not indicated right away, but in some cases, a provider may be concerned about it getting worse and you not being able to either get in or get a hold of someone or get that antibiotic in time. Let's say you were going away on a trip. They may write an antibiotic and say, do not take this until your symptoms are X, Y, and Z. And those symptoms would be highly indicative of a bacterial infection where an antibiotic would be needed. And so it's not just saying, well, here, you're going to take this antibiotic because I'm nervous and I want to, make sure that you're okay. It's a little bit more strategic. It's a lot more strategic than that, actually. So what they're saying with watch or delayed prescribing or watchful waiting is we're going to give you this antibiotic, but we're going to set you up for success to know your body and know yourself and communicate with us daily to say, I'm only going to take this if my provider and myself agree that now is the time and it's really indicated. And so The CDC has a ton of awesome resources around delayed prescribing and watchful waiting. And what's awesome is that the American Dental Association is working alongside the Centers for Disease Control and Prevention to also create some of these resources for dentistry over the next couple of years.
That's awesome. Great examples too. And you said that ADA has guidelines, or is that all the guidelines that we would find?
Well, there's a couple different areas. The ADA has a clinical practice guideline, and maybe what we can do is after we get through the 4 steps here on how you can implement in your practice, we can dive right into those. The American Association of Oral Surgeons also has a really great interactive tool on when and when not to prescribe prophylactic antibiotics for joint replacements. And always the American Heart Association is also partnered to help release those guidelines for various cardiac indications as well. So those guidelines together kind of come together to help us understand antibiotic stewardship. But I would say the big news in the last year was the ADA's clinical practice guideline for acute pain management and swelling using antibiotics. The third section for the CDC outpatient antibiotic stewardship program would be tracking and reporting. And this is actually something that in large hospital systems, like I talked about before, oftentimes they have a division that's collecting data and analyzing it and constantly giving providers feedback. But in so many cases, especially in dentistry, we have a lot of solo practitioners and even small group practices where you don't have a division that's tracking and reporting this. So one of the ways that we designed this in Massachusetts is we actually created a small Excel spreadsheet that is set up to ask you a series of questions so that you can do a chart audit on when you use antibiotics. And it's set up to do it quarterly or a couple times a year so that you can constantly self-evaluate yourself, track and monitor when you're using this, and then, find ways to refine or change your antibiotic prescribing patterns so that you are constantly eliminating instances or scenarios where you inappropriately used antibiotics. And what's great is that that is downloadable and you can customize that document for your practice. And it's set up so that anyone in your practice can do that chart audit. It's a series of questions that you would get from a clinical note. And one of the best ways I've seen this tracking and reporting practice used is that a community health center in Massachusetts took this and created one of the smart notes or, the clickable like smart note forms. And they took all the questions in here and made sure that they implemented it into this note template so that if you're prescribing antibiotics, you actually have to include everything that's in this chart audit in your clinical note. And in a lot of ways, you're self-evaluating then every single time you prescribe an antibiotic.
Okay. That's brilliant.
Yeah. And then the last step is educating. So a good way to do that is a podcast like today. There are webinars, especially on the site for the state of Massachusetts. The CDC has a ton of classes and courses also on antibiotic stewardship. OSAP has some great resources as well. The state of Illinois has some wonderful resources. I really love theirs. Also, the ada.org/antibiotics. There's a couple of videos. There's a Facebook Live. There's a CE course that you can take. And there are also some chairside guides, which are great resources as well.
I got to say, those chairside guides are great because that's with the workflow, right?
Yeah.
Where here is your, that was a great resource. I have it. It's laminated. It's at my clinic. It's fantastic.
It's awesome. So that is how you implement antibiotic stewardship in your practice. But Michelle, like you said, well, that's a really great practical way to implement antibiotic stewardship. But a piece of that is understanding what the evidence says. And so if it's okay with you, I think we can dive right into those clinical practice guidelines and understanding a little bit about what is going to be going on in the coming weeks and months when it comes to antibiotic stewardship.
Perfect. I love this.
Awesome. So I guess you probably, let's back up a second and think about antibiotic use in dentistry. I always like to step out and look at the big picture because I feel like sometimes if you don't take a step back and look at the big picture, you can get lost in the weeds. And so anytime I think about or even talk about antibiotic stewardship in dentistry, one of the questions I ask is, okay, let's think about for a second, where do we use antibiotics in dentistry? And the way that I think about this and the way actually our whole guideline panel thought about it was in 2 different buckets. So preventing infections and then treating infections. And that actually makes a lot of sense. It's helpful to put it in those two buckets. And so when it comes to preventing infections, a good example that we've kind of already touched on today is I think about antibiotic prophylaxis for someone with a total joint replacement. And so we actually have guidelines for that. We also have guidelines for certain cardiac conditions to say, okay, if someone has this condition, then they should be using antibiotic prophylaxis. And if they have this condition, actually, it's not really indicated and you don't need to use that. So when it comes to preventing infections, we've actually had these prophylactic guidelines for many years. But if you take a step back and you look at the treating infections, up until this last year, there were not clinical practice guidelines on when you should use antibiotics to treat infections, especially when it comes to tooth pain and swelling. And it doesn't mean that there wasn't evidence though. And I think that's the tricky part. So when we think about clinical practice guidelines, what we have to remember is that there are research studies out there that if you read them and understand them and apply them to your practice, you can practice evidence-based dentistry. And you can use all of those articles to help understand and influence how you practice and constantly practice better, right? But what's amazing and what we're so thankful for, especially to the ADA Center for Evidence-Based Dentistry, is that they have plans and they're constantly going in and taking that evidence and conducting systematic reviews and meta-analyses, and then bringing in an expert panel to take part in this entire process to release a clinical practice guideline. And really, that's the highest form of evidence. And so when it comes to understanding the scope of antibiotic use in dentistry, what's wonderful is we have evidence across the board, but we also have a couple key clinical practice guidelines that help influence how we practice and practice safely.
I feel like I wish that we did have this 20 years ago when I started and didn't develop these routines with antibiotic prescribing that are a little harder to break these days.
Yeah, absolutely. Absolutely. And so I think listeners might be wondering, okay, so what was this guideline called? Well, it was called the Antibiotic Use for Urgent Management of Dental Pain and Swelling, ADA Clinical Practice Guideline. And I agree with you, Michelle. This is something that I've wanted for so long, but what I'm thankful for is that someone was thinking years ago to bring this and plan for this so that today we have what we have. When I think about these guidelines, what is so important is that not only is it focused on promoting antibiotic stewardship and creating a mindset shift in dentistry, because now we have a clinical practice guideline for treating infections using antibiotics, but it's also important because ultimately by adhering to these guidelines and implementing these in our practice, we're reducing the inappropriate use of antibiotics. And I think that's so important. When it comes to antibiotic use, there's the appropriate and inappropriate use. The appropriate use, we actually can't change. There are still risks and benefits to using antibiotics when it's appropriate. It's just at that time and in that indication, the benefits are outweighing the risks, right? But when it comes to the inappropriate use of antibiotics, often the risks well outweigh the benefits. And if we can decrease the inappropriate use, then hopefully we can make a dent in some of those adverse outcomes. And I don't think I've mentioned this yet. I touched on antibiotic resistant infections, but there's actually a lot of risks associated with antibiotic use. They're fabulous and they do treat infections and they do save lives. And I think it's really important to acknowledge that. But also there are risks and there are antibiotic resistant infections. They result in hospitalizations often. This increases the cost for the patient and on the entire healthcare system over time, right? It can result in opportunistic infections. So bacteria that are in your gut system, but when the commensal bacteria are altered or decreased, those pathogenic bacteria can take hold and cause infections. And you can also have adverse reactions like allergies. People still have antibiotic allergies and toxicities, and also the change to your gut flora. I mean, there's data and research coming out literally minute by minute on the effect of your gut flora on your overall health. And so decreasing inappropriate use of antibiotics and keeping that gut flora healthy and strong is really important. And ultimately, in some cases, especially when it comes to antibacterial resistant infections, mortality can result. People can really suffer and families can really suffer from the inappropriate use of antibiotics. And so when we think about antibiotic stewardship, it's not just a side thing. It's really something that should take center focus in so much of our practice of dentistry.
No, I am really glad you bring that up. And this is a battle that I have quite a lot with people, especially clinicians that have been doing it for a while. And they're like, well, I wasn't really sure. So we'll just give them some antibiotics. And I'm like, these aren't Flintstone vitamins, guys. Like, you can't just throw it at them and like nothing is going to happen. And I always joke, like, I've been victimized my whole life by antibiotics because my mom worked for my pediatrician, and a cough, a sniffle, or whatever meant that I got the bubblegum flavored liquid amoxicillin on the regular. And I have had horrible gut health issues my whole life because of just constant use of, well, maybe not only because of that, but probably because of the overuse of antibiotics. And I heard a statement once on another podcast that has always stuck with me. And it was that antibiotics are the only prescribed drug that if you take can affect me, because it's creating these antibiotic resistant bacteria. And if you become patient zero and I get it, like, I mean, this could kill me or create some very long-term health concerns just because we were, as clinicians, overprescribing, or as patients taking, even our husbands, our wives, or whatever. We just were like, I got a little cough. You had some amoxicillin left over. Let me just take that. And so that has always stuck with me. And that's kind of where I land with my antibiotic stewardship, is that keeping that in the back of my head.
Yeah. And really realizing that the decisions that you make can affect others, and making sure that we steward. And I love that word because it really is, it means you're really thinking and analyzing and making thoughtful decisions on exactly what actions you're taking.
It's so true. Would you say it's a good shift into shifting our mindset?
I totally agree. So first I'll tell you, so these guidelines are really important because they really help us make treatment decisions for patients with pain and intraoral swelling caused by pulpal and periapical conditions like symptomatic irreversible pulpitis. And for any of the clinician students, I realize we have a lot of students. So this is oftentimes when someone has lingering pain or a toothache to something that's really cold. Symptomatic apical periodontitis. This is when the inflammation has gone from inside the tooth to outside the tooth. And now the patient is also having pain when they're biting or chewing or even touching that tooth. And then localized acute apical abscess. This is where someone has a small abscess or maybe even a larger abscess that's gone outside the bone. And now there's some sort of swelling, whether it's more of a diffuse swelling, so a little bit more spread out and the borders aren't really clear, to something that's like a small, almost like a pimple on the inside of your mouth. And so these guidelines cover pain and or swelling, and then they help make evidence-based treatment decisions on whether or not to use antibiotics in conjunction with treatment or when treatment's not available. And so I think it's important to understand kind of the scope of these guidelines so that when you're thinking, okay, well, I need to make a decision on this, you know exactly where to go. And so it's pretty expansive, and I think it's something that's really helpful. Overall, if we were going to make some generalizations or understand a little bit about what did these guidelines say? What is the overall, okay, I don't want to call it a sermon in a sentence, but something where you're just making more of a summary. Here are a few of my summary statements. It's important to realize that the guidelines cover when you should use antibiotics, when dental care is available and when dental care is not available. It's super important to understand that we considered these two scenarios, because there are times when a patient has an access to care challenge. They're unable to get to a dentist, whether they're traveling or they're unable to get to the office, or they're sick at home and they can't make it in, or whatever the case may be. So it's important to be able to provide care in both of those scenarios and provide care that's evidence-based. In general, when dental care is available, antibiotics are not needed as an adjunct to dental care, unless the patient presents with systemic involvement from their tooth pain or swelling. And oftentimes a sign of systemic involvement is a fever or malaise or serious tiredness. So when dental care is not immediately available, Michelle, and a patient presents with pain and swelling associated with advanced pulpal or periapical conditions, Pulpal conditions mean, the inside of the pulp is no longer vital and it's necrotic. And periapical conditions means symptomatic apical periodontitis, or that pain on biting, and or a localized acute apical abscess means they have some sort of bump or swelling inside their mouth. This is when antibiotics should be prescribed, in addition to referring the patient to a dentist who can perform those definitive treatments. And so that may be you if you're a dentist listening and you're providing emergency care to your patients. But, if you are in another situation where you are taking those phone calls and you are screening emergency patients for a practice or even for a community health center, that's when in those conditions that you should be referring this patient to care and making sure that they get the medications that they need as soon as possible. I think another piece of these guidelines that's super important to cover is it's not just that antibiotics alone are going to solve this problem. The patient really needs to receive definitive dental care. And another piece, if you look into the research in the past, oftentimes when a patient went to an emergency room or received emergency dental care, they received an antibiotic and an opioid prescription. So something for pain and for their infection. One of the key pieces to this guideline, and something that's reiterated so many times, is that patients that present with pain, the goal is to prescribe analgesics that can be taken over the counter. And the combination therapy that's recommended in these guidelines is 400 to 600 milligrams of ibuprofen and 1,000 milligrams of acetaminophen. And these should be considered to help manage that pain. And really, it's a mindset shift. And I think we're going to go right into all those mindset shifts next. But it's a mindset shift that's really moving all of us away from using opioids and shifting towards more over-the-counter products and therapies when possible.
Yeah, that's great. And I would love to call back to our podcast with Tom Viola, because he did talk about analgesics that are not opioids. And he had that same recommendation. That was a few years ago. And I was like, wait a second, we can combine acetaminophen and ibuprofen now? Like, that's cool, because that used to be a big, big no-no when I first started. So that's great. Thank you for that reminder.
Absolutely. So I think we should go into mindsets, and I want to do something a little bit fun, Michelle.
Okay.
So I'm going to talk about the mindset shifts change, and then I'd love to hear your comments, because sometimes I think these kind of blow people's minds. They blow my mind every time I go through them. And so maybe we can go back and forth a little bit here. But the first mindset shift is that this guideline can help change the myth that antibiotics will cure your tooth infection. And this is a very common myth that so many patients believe, because maybe they've had trouble accessing dental care for years. And what they do is they have an infection, they get an antibiotic, and it takes care of it for a while, and then it rears its head again. And so in their mind, they're thinking, well, all I need is another antibiotic. But in fact, antibiotics cannot cure your tooth infection. But dental care, definitive conservative dental care, which is a term that we referred to a lot in the guideline, will. And so in medicine, and I gave this example in the beginning, we've gone through the same thing with upper respiratory infections, if you caught it at the beginning of the podcast. So oftentimes, people thought that you could cure this virus with an antibiotic, but that wasn't the case, right? We need to make sure we're using antibiotics to take care of bacterial infections. And so in dentistry, we still have a little bit of a mindset shift around the use of antibiotics for tooth infections. But in the Massachusetts State Toolkit, we have a poster specifically designed to communicate this truth. And it's something that you could use in your office.
I'm curious too, do you guys so you said, it doesn't cure it. And we need to have some kind of definitive dental care. Is there a timeline that's ideal? Because once upon a time when I would have a patient that maybe needed endo, and we would start them on their antibiotic regimen and then send them to endo. And we're like, do not go past 5 days. I mean, is that still like the idea, or is that also shifted?
So mainly the way that we would recommend is as soon as possible. And a lot of times the verbiage in these clinical practice guidelines is an urgent referral. So really trying to impress the fact that there isn't a day, it isn't 5 days, it isn't 3 days, it isn't 7 days or anything like that, that you need to make sure that you get over there and receive your care. But there is a huge sense of urgency behind, okay, you've received your antibiotic, you've now been referred because it's what's necessary. We want that referral to happen as quickly as possible.
Okay, great.
Well, the second mindset shift, this one we just talked about a little bit, but I think it's important that the guideline can help change this idea that antibiotics and opioids are needed for pain management, specifically the combination. So many patients think that they have to have an antibiotic to manage the pain. And oftentimes they think they have to have an antibiotic and an opioid for pain management. And this guideline, it's not that we're trying to say that we're not promoting excellent patient care and treating oral pain. We totally are. That's what we just talked about. We recognize that toothaches, and when I say we, the entire guideline panel of experts that have been practicing dentistry for so long, we recognize that toothaches are excruciating and that patient satisfaction is important. The focus of this guideline is to bring to surface the recommendations for using that combination therapy of NSAIDs or ibuprofen and acetaminophen for pain management instead of controlling this pain with antibiotics and opioids. And that's something that we've really focused on communicating throughout this guideline, because you can manage pain very well with this combination therapy. And the research actually shows that combination therapy works better than opioids.
Man, I wish you could make that a PSA like we used to on like the more you know kind of jingle that goes with it.
Exactly. I think that's great. The other mindset shift, I would say that we've kind of touched on, but I want to bring up one more time because I think it's so important, is this idea of using delayed prescribing. And I think it's kind of confusing when we are able to use that in dentistry. But the point that you just made about, okay, so we have this patient and we're now referring them to a specialist is a really good example of when we can do that. And what a dentist can do is they can write a prescription. And this prescription can only or should only be filled by the patient if their signs and symptoms don't improve. And the dentist can actually have a conversation with that patient on what those signs and symptoms might be and participate in close follow-up to make sure that they take it when it's necessary. As I mentioned before, the American Dental Association is working alongside the Centers for Disease Control and Prevention to create these resources. But a good example of when this might be helpful is when dental care is not immediately available. So remember how I talked about before the guideline, we have recommendations for when dental care is available and when it's not available. A good example of when it's not available, if a patient has a necrotic tooth, so their pulp is no longer vital, and they have symptomatic apical periodontitis. And the way that I explained that before, remember they have tooth pain, but they also have pain on biting and touching that tooth. Let's say this patient is then referred for care, but they weren't going to get it within a few days. You can provide them with a delayed prescription so that if for some reason in the next few days until they get to that specialist, they start to notice any swelling, they can start to take that antibiotic, because the next recommendation in that subset of scenarios is that, okay, this patient has a necrotic tooth and a localized acute apical abscess or swelling, then antibiotics are indicated. But if they don't have that abscess yet and they have pain on biting, they have some discomfort, you know that their tooth is necrotic, then you can actually give them that delayed prescription and say, we're only going to have you take this if swelling arises. And if swelling does not arise and they're able to get to that specialist on time, then that's a really great opportunity where delayed prescribing works super well because they ended up not needing that antibiotic.
Perfect example.
Lastly, the new tools and terms such as delayed prescribing are new to this profession. And I think it's really important that we all realize, myself included, that we no longer need to write an antibiotic prescription just in case. And we really need to shift and have confidence in this idea that we're only going to be writing prescriptions when they're absolutely needed. And just like you shared with your own personal story, I think in the past, so many healthcare providers provided antibiotics just in case because maybe that's the way they were trained or what's communicated. But now our evidence shows that we should really only be prescribing antibiotics when they're absolutely necessary.
I think that's a great reminder. And I'm also curious because there was a mindset shift that I think you talked about at OSAP, and that was taking the full 7 to 10 days.
Yes, I was hoping you were going to bring that up.
Oh, good.
So if you take a look at the recommendations from the American Dental Association, the clinical practice guideline, and let's say you go to the chairside guide, Michelle, because you're obsessed and you already told me that you have it printed out and laminated, and you look at where they say, okay, the expert panel suggests dentists prescribe blank, and they put in an antibiotic. And then usually in the parentheses after that, the milligram or the dosage is there. And then how many times per day that you're going to be taking that antibiotic, whichever one it is. And then after that is the number of days. For many of them, and I'll just give an example of amoxicillin because you've already brought that up today, it's 3 to 7 days. And when I grew up, and I'm sure when you grew up and when many of the listeners grew up, you did not take your 7 days of antibiotics. And if you missed one,
Nope,
you were in trouble. Well, there's actually a huge mindset shift. And I did talk about that at OSAP this year. We had a lot of discussion, but if you look at the evidence, having a shorter course of antibiotics does not necessarily lead to antibiotic resistance. And so the way the 3 to 7 days can be applied to antibiotic use is, let's say you have someone that comes in with tooth pain and swelling, and you give them a prescription for oral amoxicillin, 500 milligrams 3 times a day. They should start that, and then they should finish it 24 hours after their symptoms resolve. So when their swelling resolves, let's say they already received dental care or, an open and drain or root canal therapy, when their symptoms resolve and their swelling goes down 24 hours after that, they can discontinue the use of that antibiotic. And for some patients, that may be 3 days. For other patients, they may have to take the full 7 days. But really, it's up to the patient's body in that sense, where you're closely following up, closely monitoring. And that's the role of the dentist and the dental team, right? So closely monitoring this patient to ensure that 24 hours after their symptoms resolve, they know that they can discontinue that antibiotic.
And I think that might have been my hardest hit mindset shift. I was like, wait, what? No. Like there was you did not forget. You did not take the full course of antibiotics. So I was happy to hear that, because I was dealing with my own biases.
Mm-hmm. Yeah, absolutely. Well, and that's where having good conversations and even role playing that with patients is really important. I know, for me as a provider, when I practice that way, sometimes there is a little bit of resistance, and making sure, and what I love about the chairside guides is that I will pull them out and say, okay, let's walk through this together. And I'll sit side by side with my patient and say, all right, so you came in today and these were your symptoms. And from that, I know that your tooth is alive or no longer alive. You have a swelling, you don't have a swelling. And so we walk through the decision-making process and the chart together often if a patient is really nervous. And then I'll go to the flip side and say, well, this is what the evidence recommends. And we read that statement out loud. And then I explain it to them, and I explain how we're going to use the antibiotic, and I explain why. And once they do that, it's like the light bulb goes off, and they are so on board, because they realize not only are they helping keep themselves safe, but they're also participating in helping keeping the community safe and healthy as well, because of your comment earlier. So it's so cool when patients really come on board with antibiotic stewardship, and they realize how powerful antibiotic stewardship is in the grand scheme of keeping everybody healthy.
Well, I think that's a great example, because one of my questions for follow-up was going to be about patient pushback or patients actually following the directions of delayed prescribing. And so if you give that antibiotic or that prescription, you're like, hold off. Do you have any issues with patients? You're like, yeah, no, I'm just going to do this, because we all got those patients, right?
Yeah. So I thought that I was going to have that. I really did. When I started, I won't say I always practiced antibiotic stewardship. I really tried to always practice antibiotic stewardship. I found when I started this project that I was going back into my notes years before. And when I was in residency, I had all these charts on antibiotic use, and I was constantly reading Lexicomp and reading and asking questions. So I think I've been obsessed with antibiotic stewardship for a decade now. And so I thought, okay, I've educated a ton. I mean, I sometimes will have patients like roll their eyes like, oh, here she goes again. This is one of her things. But I have not had anyone that did not want to practice the delayed prescribing. In fact, I think they liked it because I would give them permission. I'm like, hey, here, go ahead and give me a call if something changes. Here, if you have a question, feel free to give me a call. And we had a little cell phone for our practice that was really easy for people to get a hold of. And sometimes they would call me, but for the most part, I had an information sheet that I used, and they said, Dr. Kennedy, I'll call you if I need to, but I get it. I'm going to follow through. And for the most part, they were super on board. I think most patients, especially in today's day and age, don't want to have to take medication that's not necessary. And so many patients are saying, I want to follow your directions. I just want to be healthy. If you can just help me make these decisions, I'm on board. I also think the approach that I use, where we go through the chairside guide together, we make a co-decision. As soon as you're making co-decisions with your patients, and it's not me telling you what to do and that more paternalistic approach to healthcare, and it's more like I'm sitting next to you and we're going to decide together. As soon as you shift to that co-decision making process, I've had patients really take hold of understanding when they should be using antibiotics and when not. And also, I have a lot of close follow-up with my patients. So this example is no different than me following up after they receive other care or either at our office or with a specialist.
And I was wondering if you could give me some suggestions for a situation that's happened to me quite a few times. And I know it's happened to a lot of my fellow hygienists. And that's when we are being a champion, going through the health history. We're talking to our patients. They sit in our chair and they say, I'm going to need another prescription for antibiotic pre-med because I have had a hip replacement 8 years ago. And we say, well, actually, we have some new guidelines, and we go through that whole thing. And then we call the orthopedist to make sure, am I missing any reason outside of the guidelines? Was there a recent issue? Was there an issue during surgery? Whatever it is. And they go, nope, we do it for life. And I say, well, the guidelines now state X, Y, and Z. I'm curious if there are any of this happening with the patient that I should know about, and a reason that we would shift outside of the guidelines. And it's always like the nurse or the front office team that's like, that's just what we do. And I don't sometimes know how to take that.
I've ran into that as well. I ran into that actually a few times when I was at a federally qualified health center, and I was a part of a larger hospital system. And there were kind of departments that had that mindset. And I remember one of the things that I offered to do, and this was kind of a bold move, but I really wanted to make sure that the message that I was sending was saying, we are on an interdisciplinary healthcare team, and X patient, and I always called him by their first name, needs us to work together. And I feel like we need to review these guidelines so that together we can make a really good patient decision. And I remember calling and saying, I need to speak with this other provider. And so I would get either the surgeon on the phone or the doctor on the phone, the primary care doctor. And I would say, can we walk through these guidelines together? And I said, if over the phone doesn't work, I'm happy to come to your office and meet in person whenever it works best for you. But I was like, I know that we're going to be sharing a lot of patients moving forward. And I just want to make sure that we're on the same page when it comes to providing them with evidence-based care in your office and in my office. And I feel like in order to do that, we need to work together. And typically when I phrased it that way, it worked out really well. It was very rare where I was like, you know what, I'm not getting anywhere. I'm hitting a brick wall. That really didn't happen, because as soon as I framed it like, we're on this team together and we need to practice this way in order to provide, let's say, Michelle with the best care possible, right? It kind of shifted the focus from this is our system and this is how we do it to, oh, wait, I'm taking care of Michelle and my focus is on making Michelle really safe and healthy. The Illinois State Toolkit, and Michelle, I can send you a link. I can pull that link out of that toolkit. They have a great training for communication around antibiotic stewardship for healthcare providers. And I think that would also be a really great tool if you feel like you constantly, I wouldn't say constantly, but frequently have to battle this or face the same challenge. I think that training might be really helpful too.
Oh, that would be fantastic. And do you feel like that message, that conversation where you say, I need to speak to that surgeon, that doctor, that dentist, or whoever it is, should come from the dentist, or me as a hygienist, could I offer that as well?
That is a really good question. And I'm going to admit to you, that's a hard question. I would say at my...
Really dependent on the practitioners.
I think it's really dependent on the practitioners. Just this last year, I had one of the lead hygienists at my office was also actually a dental hygiene educator. And so she was very used to having these conversations and felt super confident. And so it was very rare that I would ever step in and say, if she got to a point where she's like, Dr. Kennedy, I'm just not getting through. I don't even know if that ever happened. But at another one of my practices that I was at, I was in a part of a larger healthcare system, and the system or the way that they were practicing, because it was such a big hospital, had such an influence on the way healthcare was delivered, because it was more, I don't want to say a machine, but that's what we think of when we think of large healthcare systems, right? It was just more of like, this is the way things are. This is the system. Oftentimes in that case, I would have to step in. I would say for smaller offices and smaller healthcare facilities, what I've noticed is that once we go through this training as a team, my entire clinical team feels pretty confident in communicating, this is what the evidence says, and this is how we would really love to care for Michelle. And this is, our goal for her care. And, we really want to make sure that we provide care together as a team. Usually that takes care of it. The time that I've stepped in is when it's a part of a very big system that is just kind of moving forward and making more system-wide or system-level decisions. And that's when I've gone in and said, okay, so we need to sit down as a team or as an entire department or as the chief of surgery and say, I need to walk through these, because if we can't change individual decisions, then we need to go in and change that system to make sure that system is reflecting evidence-based care. And I will say that that's a bold decision, and that's really hard. But at the end of the day, you have to think, you could change the lives of X thousands of patients for the next 20 plus 30 years, 50 years, depending on, guidelines are released every 5 to 10 years, depending on the situation. And you can really impact an entire populations of patients in the region by advocating and making sure that the interdisciplinary care that you're providing is evidence-based.
Well, I think that's a great mindset shift to really close out our episode today. Just the idea that once upon a time we gave antibiotics just in case to protect the patient. And really the shift is now not prescribing it to protect populations and a generation, and maybe in some of our cases, because we could be causing more harm than good in some way.
Absolutely. I think that is a very good summary of what we've been talking about over the last hour. And I'm so thankful to be on here, Michelle, and to have someone who is so passionate about antibiotic stewardship like yourself. You asked some really great questions.
Oh, thank you. And thank you so much for your time. Thank you for being a steward and being a part of these panels, and really kind of being a champion in your own, well, definitely in your own way, and helping us to better understand it.
Well, thank you so much for your time, Michelle. And I'm so excited to be on your podcast today.
Thank you so much. And check out those show notes, because we'll have all the links that Dr. Kennedy spoke of today in our show notes. And this is great. Thank you. Andrew, when's the last time you took an antibiotic?
I mean, okay, I don't know where you're trying to go with this question, but
I'm just curious.
Ever. Maybe
never?
Maybe once or twice in my entire life.
Wow, really?
Well, you have to go to the doctor to be able to get those prescriptions.
True.
I'm just one of those guys. I just never go to the doctor. So
no. And so I just came from working with the people over at Tepe, they're a Swedish company. So all my like people that I worked with were Swedes, and they would constantly say like, I don't think I've ever taken an antibiotic. And it just blew my mind, 5 years ago, and they're like, yeah, we don't take antibiotics. I'm like, I don't even understand what I go and I sneeze in the waiting room of a doctor's office and they're giving me a Z-Pack. So I don't even understand that. But yeah, they are not prescribed antibiotics in the same way. And I say this in the episode, but my mom worked for my pediatrician. So, I mean, there was no question about it, what am I now? 30 years
55.
ago. Shut your face. 30 years ago, I was like pretty much drinking a liquid amoxicillin, that bubble gum flavored amoxicillin, man. I'm like, here, just take a swig. You'll be fine. So gut health, all of that, man, we got to really consider our antibiotic stewardship. And so I thought this was an excellent episode.
It was very timely.
Very timely. So if you guys want to reach out to Dr. Kennedy, all her stuff is in the show notes. The resources that she talked about are in the show notes. Check that out. You'll be able to also find the CE link to get take the test so you can get your CE credit if that's what you so desire. A lot of states are going to like taking away that in-person stipulation, even South Carolina just said that, okay, like it can be online. And I was like, that's awesome. So this year, if you want to get all your CEs through a Tale of Two Hygienists, you could do that.
No, yeah, exactly. This year might be the only year, so hurry up and do it. But
yep. So you can find the link in the show notes. And also, if you want to rate and review this podcast, you'll find that there as well. And if you want to follow us on any of the social media platforms, please do. And you can message us there, mostly Instagram and Facebook. Follow us if you aren't already. And please subscribe to our newsletter because we have tons of great things happening. We're sending them out, I'd say every week or so now, but I promise it's information that's really relevant and even topics maybe you didn't realize we had talked about on the podcast that might interest you. So subscribe to our newsletter by going to tale2hygienist.com. Anything else?
For sure. No, thank everyone so much for listening. Oh yeah, that's all. It's been a good week.
All right, y'all. Have a great week.
Take care, everyone.
Bye, y'all.